come back in. So I'll just hang on a second. Jackie, the next page is yours.
Don't drink it.
No. Move the sanitizer out of the way, then I didn't swing that by mistake.
Get a drink next to the sanitizer.
Just waiting for Sarah on this. Okay, colleagues, shall we make a start? Thank you for that. This is a long meeting this afternoon, but as you've gathered, some very, very serious reports that we've got to consider with major implications for the work the Trust has been doing and we will continue to do. So we'll carry on with the agenda. The next item is item 165, the Maternity Safety Support Programme Diagnostic Report and Maternity Quality Surveillance Monthly Update. Carol Carlisle, welcome.
Thank you.
Jackie, over to you.
Yes, thank you very much. So, as the board will recall, last month we had Jess Reid, who's the Deputy Chief Midwife of England, giving us an update of where she was with her diagnostic review under the Maternity Safety Support Programme, and she advised us that the report would be available the following week, and it was. So what we're going to do today is I'm going to invite Carol to talk about the report and the areas that we are focusing on, but also to give us an update on the quality and safety surveillance monthly update. So Carol, I'll hand over to you.
Thank you. Hi, good afternoon, everybody. My name's Carol Carlisle and I'm Head of Midwifery, but focusing on governance. So as Jackie said, we brought the report as an update for the Maternity Safety Diagnostic, well, the Maternity Safety Programme and the first diagnostic report. Within the report, the focusing initially first on 3 areas, and that's leadership, governance and maternity strategy. The next part of the report is outlining the perinatal safety and quality data. So this is the first of a monthly report for the perinatal safety quality data, and it's minimum data that we have to provide to the board to ensure that you've got appropriate oversight of maternity services. I'm taking that the report's been read. Other than, has anybody got any questions or anything that they'd like me to explain any further?
Looking round. No, Carol, I think you're quite right. It's a very good report. It's very concise. We've read it. Doesn't look like anybody's got any questions or clarification queries. Oh, Chief Exec, this one.
Carol, you're very, very welcome. Just, you mentioned that the report's based on the minimum data set that we need to submit. Is there anything else that you'll be recommending outside of the minimum data set that the board should be considering that we might want to develop further in future reports?
Yeah, so what we're doing at the moment, Aaron, is we're doing a piece of work to make sure that we're bringing the appropriate data to board. So the idea is that we're going to bring this on a monthly basis, and then we'll have a quarterly bigger report to look at. And we're working through all the key drivers like CNST, CQC, Ockenden, and actually those are the things that we will bring into board for oversight. So this is a starter for 10 for that minimum monthly data. Does that answer your question?
It does, Carol, thank you. I've got a follow on if that's all right.
Of course.
Yeah, and in the report, or in your view now, is there anything in those metrics that you want to draw the board's attention to? Is anything particular areas of concern or themes that you think we need to pay attention to for next reports?
So I think, and I guess this is wider across the organisation, it's the cultural work that we're really trying to get underneath and to the bottom of, and I think a lot of work of that is being done. And once we've got that underpinned and we're looking at the strategy and all the safety metrics, I think that's the thing that we will be bringing and highlighting.
Okay, thanks, Carol.
Okay, Jackie?
Carol, I just wondered, it's Jackie here, if you wanted to just talk a little bit more about the work you've been doing with our colleagues in business intelligence and the work of the metrics, because we're making sure that we can provide that evidence on a monthly basis as part of your quality surveillance, but also that links into the national picture of where things are going and the regional picture.
So what we're trying to do is we're trying to make sure that we present the data in a meaningful, concise way to the board, but also how that links up into the national drivers for the national maternity dashboard that will give the quality metrics, and also how that will fit in with the maternity support programme as well. So it is a piece of work in progress, and the idea, and this is going to be regionally driven, that we almost have a one sheet that has lots of infographics on that gives you the right information. It's very visual and you understand straight away what the issues and the heart of the issues are and what actions we are taking to address those. And it's working closely with I3 as well and looking at how we feed that into the rest of our reports as well.
Thank you. There's a question from Bruce, Carol.
Hi, Bruce.
Hi, Carol. Thank you for a very good report, and a report that assures me as well. Just a couple of related issues. First of all, how's it's probably more to Jackie and David Wilkinson. How's progress with the recruitment director of midwifery? And secondly, how we've made midwifery recruitment a priority, as we'll see in the integrated performance report. How are we making progress on that? I don't know whether yourself or Jackie or David want to answer those points, please.
We'll direct that to Jackie in the first instance, then ask Jackie to direct it when necessary.
That's fine. Thanks, Bruce, for that question. So the director of midwifery is out to advert again now. And we've been working very closely with Jessica Reid, the Deputy Chief Midwife of England, and Dr. Marie Lewis, who's working with us on this to see if they can identify people who may be interested in coming to Morecambe Bay, either as a stretch assignment or a 12 to 18 months secondment, so we can make sure that we've got the flow in there if we don't get the Director of Midwifery post appointed to this time, but we haven't had the conversation yet with the company that are leading that recruitment for us. With regards to midwives within the service, Carol probably would be able to answer that better than I can.
So we're doing a lot of work in terms of retention initially to keep the midwives here that we've already got, and we're using the Ockenden money. As part of that retention work and engagement work, we're actually going out to our staff, and we've started, I think we've had one workshop to say what sort of recruitment package do we need to put together to draw people into our organisation. We've also got ongoing recruitment drives. We've just appointed 3 midwives into our organisation, and I think the idea is to be that recruitment drive to be competitive, because we all recognise that there's a national shortage of midwives, and I think we just need to be up there selling our services and how great it is and to come and work for us and how it can be.
Thank you, Jackie. Thank you, Carol.
Thanks, Bruce. A couple of questions from me, Carol, related to the report. Paragraph 16 on the perinatal mortality review tool. Can we have some assurance to the board that case 2 has been brought to a panel that's been reconvened? Can we just get that through? Do we have a date for that? Do you know?
So as soon as we've got a date, I can bring that back to you. One of the challenges we've got at the moment is for that external oversight. So as we are challenged, our colleagues within our area are challenged. So as soon as we get that date in, I can forward that so that everybody knows that we've got that in. I think sometimes what we have to do is when an opportunity arises, we take it. So say, for instance, on Friday, we managed to get an external obstetrician and we managed to get a panel together. So whilst we don't have a date now, sometimes it's about finding that external obstetrician.
Can you just make a note that in your monthly update, you let us know?
Of course, yeah.
And then paragraph 20, you said that, you know, full midwifery establishments on shifts is considerably improved. And then it goes on to paragraph 21, saying, but obviously there have been midwives that have been successfully appointed to other roles. What have we put in place to ensure that we keep improving full midwifery cover?
So in terms of what we do is we've got a workforce, we're working on a workforce plan. We obviously do 6 weeks ahead rotas, we send it out to bank, we send it out to agency. And then what we do very much is we have a daily staffing review. So we're always looking ahead to see what staffs we need to fill. And then of course it's all part of the retention and recruitment programme that we bring them in. So we manage it very closely on a day-to-day basis, and always are working with our colleagues who go out to agency, etc., to get those posts filled.
Okay, thank you. So for assurance purposes, there's nothing you want to bring to the board's attention in that area?
No, thank you.
Okay, thank you. Liz?
Thanks, Mike. Just about point 18 in the report, the survey user voice feedback, and that's a really important liaison role in the committee, isn't it?
Yes.
It just read there about the you've not been able to. Staffing issues have meant that there's been a delay in release of midwives and support workers to join Best Baby Friendly Initiative study days. Presumably, particularly going into December and with the changes that you've identified at South Lakes Birthing Centre, presumably you're going to be under even more pressure to join in on initiatives like that. So have we got any plans to how we can perhaps be a bit more flexible with staff to help them join these initiatives?
Yeah, so what we're trying to do in our education team, we're working through what, you know, our overall training, because what we do is we need to prioritise, because there are obviously our core training job essentials. We're doing e-learning packages. We offer people to come in and we'll pay them, or do the work from home and we pay them, and try and find out, working really closely with staff to see what format and what way we could deliver this education, so it makes it easy for them to join in.
Okay, thanks.
Thanks, Liz. Thanks, Carol. Thanks, Jackie. I can't see any more hands up at this point, Carol, so I'm going to take us straight to the recommendations. We're asked to note the content of the diagnostic report and review the monthly safety and quality data provided that you have provided. I think we have done that, and you've given us some assurance data as well, Carol. So thank you very much for your report. I'll now move on to the next item.
Thank you.
See you soon.
Thanks, Carol.
Okay, colleagues, we'll move on to item 166. This is the quarterly mortality report, April to June of this year. Jane, as medical director, please.
So yeah, it's the mortality report presenting for assurance and covers the period April to July 2021, and it summarises the data of the period and actions and learning. There is a much fuller paper, just to say, that goes through the quality committee, which has got an awful lot more detail in it than this. And I've just picked out a few areas. So it's more to know that we've now got clinical leads and a mortality steering group in place, reporting through patient safety group to quality committee. We've got medical examiners in place, and they've got the capacity to review 100% of inpatient deaths, and they work closely with the teams to prioritise the cases to be reviewed. In terms of data collection, we collect a number of different types of data, and I think it's important for us to point out that they all measure slightly different things, so we can't directly compare them. So raw data is just that. It's available to us quickly, but very limited in what we can do with it. The hospital's standardised mortality ratio measures how likely you are to die of what you were fitted with. So if you came in with a heart attack, how likely are you to die? And it's important to remember that that includes COVID deaths, but only deaths in hospital. If you've got a score of over 100, it means that you're more likely to die than expected, and less than 100, less likely to die. And the data is validated, so it's not immediately available. It takes a couple of months lag before we get it. And then the standardised hospital mortality index, which is often known as SHME, is different again because it compares the number of deaths in after being hospitalised with the number of expected deaths based on an England average. And again, over 100 is more than expected, and less than 100 is less than expected. So you can, and it doesn't include COVID deaths from June of 2020. You can see that throughout the last 12-month period reported, we've got a lot of months where our numbers are above 100. However, they fall within sort of at the upper end of the expected range that we would fall in. So we don't alert on mortality overall. But the HSMR data and the SHME data can be broken down further. And when we look at that, we have got a number of individual areas that have reached that alert level. Fractured neck of femur, respiratory diseases, stroke, congestive heart failure and stillbirth. So the actions taken around those have that we've got appropriate sort of specialty-led teams who are looking deeper, first into the data to understand the issues and to develop the appropriate actions. And we've already seen changes to pathways as a result of that. So in the fractured neck of femur pathway, we've seen that there's been increased ortho-geriatrician input and increased amounts of nutrition and cognitive function tests. I think we've had 100% of those over the last 12 months, which will improve patients' care. The other thing I want to draw your attention to is structured judgment reviews. And they're a mechanism so that we've got a sort of a consistent and reproducible way of looking at deaths, irrespective of who is performing them or the people who've got training for it. And it's a combination of a sort of a scoring tool, pro forma, and clinical judgment. Initially, it was done in various areas in the trust, but we're now developing more oversight so that we've got as much information as possible to inform learning. We use a criteria for which deaths should undergo a structured judgment review based on Royal College of Physicians' best practice guidance. And we're also working with the community team to try and extend this to include all community deaths, because there's learning around that, not only around care, but also sometimes around where we could have avoided admissions in some patients. So we've actually identified from those that there are 3 deaths which were probably preventable, was the overall classification. And one of those was a patient who had a learning disability. So the processes are in place to ensure that we've reported these incidents and applied appropriate duty of candour. I don't have outcomes of those things at this point because this is not, they've not gone through all of those necessary processes. And we need to use that learning to drive change if necessary, but thematic analysis is really useful not only to highlight issues, but also to highlight good and excellent practice, which we do see, and which we also then need to look at using wider throughout the organisation. So in summary, really, the mortality process is now in place and has a clear reporting structure. We're aware of mortality indicators that are at the higher end of the accepted range and that the specific areas that we do raise an alert on, and we have got work ongoing to address those areas. And we're using structured judgment reviews to ensure that we've got consistency of looking at deaths and that we're taking learning from that, whether that's good or bad.
Thank you. Thank you for the report. It's a good, concise report. It's really pleasing to see that we've got the mortality steering group. It's also good to see that there are quarterly reviews and the quality subcommittee, except the patient group, are now looking at that and they're using the structured judgment. So thank you for that. And it's pleasing to see that there's progress in those areas. Any comments, questions? Go Liz and then Jill.
Thanks. Thanks, Jane, for presenting that. Just wonder, is this a national thing that stillbirths aren't reviewed, or is it just our trust?
That's the national guidance as far as I am aware. I don't look specifically, but I'm pretty sure that we have not chosen to not do them.
Yeah, it just seems that
They're
it's
done
actually-
differently.
Ah, okay. So I was going to say, surely
Yeah.
from a parent's point of view, they possibly would want to know, was there any
I
contribution?
suspect it's possibly also the fact that there's small numbers, so a single one would make a huge difference numerically. So there's probably not a valid way to look at it.
Yeah, it's a national programme for child deaths called Child Death Overview Panels, if it's still the same one. So that's how they've done there. So the learning is taken from that, but it also feeds back into the trust.
Okay, thank you.
Thanks, Liz. Good point. Jill?
So just picking up Liz's point, we do see at Quality Committee when there's national reviews of ours through the national programme of looking at stillbirths and lessons learned. And those reports are fantastic, and they're largely written for parents, and they're in plain English, and they're just great to read. Because they actually explain it so well. So I think there's a lot that we could learn in terms of looking at reviews from the babies and children's perspective. But there's a couple of questions I had. First of all was about the mortality steering group, and we've made masses of progress in that work. But there's some recommendations from the niche review about how we do mortality things. So just some assurance I'm after about that the mortality steering group will be involved in that. That was one question. And my second question was, we've got this external target of 100% of surgical deaths being subject to such a mortality review. And we're not there, we're not at 100%. But how does that compare with other trusts? I don't expect an answer of that now. It's just it would be useful next time it comes to Quality Committee to have some comparative analysis if that's available.
I don't know if it's sort of reported and available, but we can certainly do some asking around.
Okay, I'll come to you in a second, Jeff. Jill?
And the first issue about the mortality steering group, will they be involved in looking at the recommendations from the niche report on mortality reviews?
Yeah, and I think as well we did some earlier work in the summer with I think it's Dr. Jean McLeod, who's nationally leads on this, and I think we need to probably invite her back here just to come and help us at this time, just to see that we've got the best process in place. So that will happen.
Thank you.
Jeff?
Thank you, Chair. I guess you'll be pleased to know my hand function isn't working, so so you may not have to listen to me much longer. But you know, death isn't usually a great place to be, but actually I think it is in terms of learning. And I've been involved in, I think some of you heard me say this before, forgive me, but I've been involved in mortality reviews before at Furness General, and I thought they were extremely useful. So I've got just a couple of thoughts. First of all, in terms of mortality reviews, you know, think about the whole pathway, and sometimes you need to know what's been going on in general practice, primary care, community services, and actually occasionally having a GP there might introduce a bit of challenge and stop a group developing like group think and feeling too comfortable amongst themselves. So that's just a thought. I wonder if many on the board understand the role of the medical examiner, because you've referenced it in this report, but actually Jane's referenced it in the report. But there've been recent changes, and actually I don't understand them very well. I just wondered, Jane, whether you had any comments on what the medical examiner is, who it is, and what they're actually doing, and what benefit they're bringing, because the rules have changed, haven't they?
Yes, and also the rules are going to change out there around reviewing community tests. So I'm wondering whether it might be better to bring it back as a somewhere as a I don't mean a presentation, I guess, for want of a better word, and perhaps actually
there actually. I was going to propose, and it might encapsulate your point here, Jeff. The final paragraph on your report says that the fundamental purpose of a mortality review is to learn from deaths. And work continues to ensure that the learning is appropriately cascaded and used to improve care for patients. Now, I don't want the board to replicate the work that quality does.
No.
The quality committee will look at the death and that, but I'm just wondering if when we have the patient's story, if we could have, I'm sensitive to the issues here, but if we could have a patient that's died and what's been learned from that, how it's been cascaded, and include then the relevant roles of the appropriate officers so that we get a full grounding, just so that we can capture for assurance purposes, where is the appropriate cascading of learning and how is it improving care of patients? I recognise it's sensitive.
It's whether we can serve the same purpose without making it quite so explicit, and instead of using the patient story, we use that space for some deep dive learning for the board, and we bring the mortality review process and the role of the medical examiner just for board learning into that space, Chair.
And what the learning is from a sample, rather than repeat the quality work that the quality committee does. It's just so we can get some assurance around where is this being cascaded and what is the learning. Jill?
I was going to say, in the quality paper, we do have the learning from mortality reviews, which is really interesting. And just picking up Jeff's point, we also look back into primary care sometimes. And an example of some of the learning has been people who come into hospital largely from primary care, and they're elderly, or they may have had a fall at home, and then they get operated on and then they die. So the last parts of their lives are fairly unpleasant, to say the least. And one of the bits of learning would be, should they have been in hospital in the first place? And there've been some work following on from that, for example, about how we work with primary care to look at alternative ways so that people can die comfortably at home. And that's been one of the things we've learned from the mortality reviews. And actually picking them up. So there is some very interesting stuff that's come through the quality committee.
And if we just ask, because we do the mortality report, but if we could just, if I could ask the executives to look at that, and Paul, if we could work on some agenda time, at the very point that Jill has said, you know, so that we're not looking at specific mortality, but you can give us some examples of where learning's occurred and how that's occurred, and that's embedded in the area where the learning does occur. Is that okay?
And would we do that along with the next quarterly paper? Was that
That's, if that's appropriate.
Sort of coincides,
That
doesn't
yeah.
it, nicely then?
And also answer Jeff's thing so that we get a more rounded view of the role of various officers. Thank you. And Jill, thank you for that, about the work that you're doing in quality. We're asked to note the quarterly mortality report. I think we will do deep dives on it so that we can get further assurance. And we'll move on then to item 167, Deputy Chief Executive. This is the Integrated Performance Dashboard. Over to you, Chris, and how you then take us through this report, please.
Thank you, Chairman. Similarly to last time, I'm just going to introduce a few things to add to the context of the paper, and invite my exec colleagues that have got a couple of points of update that they wish to give. So within the report, the connection between the respective challenges of the continuing high pressured operating environment and the quality and safety agenda is highlighted, specifically in relation to the challenges of maintaining infection prevention protocols through complex patient pathway management challenges, and specifically in respect to the risk associated with patient falls. The report makes reference to a number of incidents where there have been exceptions in this regard that have been reported to the Director for Infection Prevention and Control, that's the Chief Nurse, and mitigating actions have been established and reviewed on a daily basis in order to manage the identified risks. The learning from this process supports a review of the relevant protocol and recommendations in this regard, and are currently being consulted upon. In addition, there is a statement within the report that the high number of falls directly relates to high occupancy rates, and the board will be aware of the extended period of pressure that the trust has been under and continues to face in this regard. So whilst the number of falls reported has risen, the number of falls which have resulted in moderate harm within the reporting period remains low. And the Chief Operating Officer will provide an update in respect to the development and progression of the urgent care recovery programme through which system partners are seeking to have a direct impact in this regard as we head into the winter period, which directly relates to the comment around criteria to reside challenges referenced within the report. Whilst the board has advised within the report the most up-to-date mortality data was not available till the 12th of November, the board of course has just received the quarterly mortality report separately on the agenda for today's meeting. So with your permission, Chair, I'd invite Chief Nurse Medical Director to add anything at this point, and then I know Kate, the Chief Operating Officer, will provide an update on the progress on the urgent care improvement programme, which directly speaks to some of the key notified risks and issues within this report, as well as an update in relation to elective care and cancer access standards. And just very quickly, so there is a reference to a number of key issues in respect of the people section of the report, and in particular, the Director of People and OD would like to provide a short update on mandatory vaccination. Then I'll conclude, Chair, if that's okay, with an explanation of the month 7 financial information.
Chris, rather than you pass the floor back to me, I'm comfortable if you direct colleagues to come in and speak at the relevant time. So if you just ask your colleagues to present in the order that you mentioned, I'll leave the floor to you till all the reports are completed.
Okay, just one. So first up on quality and safety, it's just any update that Jackie wishes to provide.
Thanks, Chris. So there's 3 areas I just want to address, if I may, from the report. So Chris has mentioned the issue of COVID and where we've had exceptions around infection prevention and control protocols. This was actually identified as well through our executive review group, which I've already described earlier on when we were discussing how we are assured about triangulations of issues. So we asked for a thematic review to be done on those, and that came back to our executive review group about 2 weeks ago now. And there were certain things we've put in place. So there is now specific exception reports that come to me on a daily basis. So as the Director of Infection Prevention and Control, I see those, and also to understand the placements of patients. But we've also gone adapted our protocol to talk more about patients going, as the COVID numbers come down, that we start using our side rooms more to take these patients in rather than using bays on wards. So we've done that. So we've changed our process around that, and we're hoping that we're going to see a bit of a drop in the number of nosocomial infections, which is like transmission of COVID between patients. Sometimes, as it always is the case, you don't always know a patient has got COVID. They may have been screened out as not having COVID and then may develop it. So it's always a difficult balancing act, but we have done that, and I'm hoping that we're going to see by the next board that there's been some improvements in that. The second thing I want to mention was around on page 87, which is around the VT assessment data, and you'll see that's been withdrawn from your packs. There was a discussion at our risk management committee yesterday about and ask if we could reduce the risk score on this down to a lower score, but we as a risk management committee were not assured that we were doing things right, and this is borne out in the fact that we've had to take that data down to have a look at it. So we were just seeing a gentle decline each month of the requirement to meet that 94% profile, which keep dropping off. So we just want to have a look at that, and that should hopefully be back up next month. And then the last thing I wanted to mention was on page 88, and again it's about the safe staffing work. So what I want to show on these on the slide deck, and which will be make it quite busy, I want to be able to show every ward against their planned and actual staffing and the fill rate of what we achieved, because I think that's the real quality indicator we need to be looking at. So just so that the board is aware, next month, having it been to the People Committee on the 15th of November, we will be bringing the first of 2 reports in December and January around safe staffing. I just want to advise that there's been a real forensic review of how we've been managing our data around safe staffing, information we've been uploading nationally, and where we believe we are at. So that is going to all come in December, and then in January, Bridget, as our new chief nurse, will be bringing the final part of the report. And just to say that Bridget has worked alongside us in this work, so it's not something that she's going to get handed to. She has been part of it, so that was really important. So I'm happy to stop there and take any questions. I don't know whether Jane, you have anything that you want to mention, or Richard.
No, sorry, I don't have anything more to add.
Thank you, Chris.
Good summary. Thank you. We look forward to the reports coming through to the board. Jackie, can't see any questions, so back to you, Chris.
Thank you, Chairman. Kate, did you just want to give the update on the operations piece? Thanks.
Certainly, I've got two issues to pick up. First of all is progress with the urgent care recovery plan, and then secondly, an update where we are with recovery, excuse me, restoration, all to do with the elective. So pleased to advise that the urgent care recovery plan has been finalised. I think colleagues will know it's been in development for quite a few months now, and the vast majority of the initiatives within the plan we've now secured funding for them, which is really good. That when we apply our data modelling and project through winter through to the end of March, it's still showing us at over 100% occupancy, so still far too full. So the job is not done yet, and we've got a number of what I refer to as the sort of transformation initiatives that we now need to be working on and really pushing forward, all focusing on reducing occupancy, so admission avoidance, reducing our length of stay, and improving discharge. So we had a stock take with our colleagues from NHS Improvement, our Improvement Director and Lorna, and we went through all of those, and we've agreed a list of 8 or 9 priorities that we need to be focusing on. And these include things like same-day emergency care, so turning people around at the front door and supporting them with community support at home. Focus on the frailty coordination in the community, so it's about strengthening it up, but also if people then do arrive at ED or into our assessment units, if they are frail, that we have more intense support and intervene against. So we try wherever we can not admitting them, because they are best at home in their own houses. Focus on no corridor care, and better ward and board rounds, which all focus on shortening that length of stay. The big one in here is the numbers of patients that are not meeting criteria to reside. So this links in obviously to the difficulties being faced across the care sector, and we've been seeing our numbers rise, unfortunately, with this. So there's daily focus on these delays, and probably has been for the Cumbria part of our patch for 2, 3, maybe even 4 months now, but we're starting to see those delays accrue now for Lancashire as well, which is very worrying, particularly at the Lancaster site, because of course there's such a high proportion of Lancashire patients go into the RLI. So there's daily focus on those delays, and we're working with our partners, so that's in local authority and across with the CCG primary care as well, to just explore all sorts of different ways in which we might help each other on this, just to alleviate this situation. It's important to note at this point that we recently reviewed the risk score of our urgent care in our winter plan. It's normally positioned at 16. We've raised it to a 20, and we've reviewed that, and it's remaining at a 20 at the moment, and we'll be keeping an eye on that and coming back and looking at that on a regular basis, and progress on that, and the whole plan will be managed through our new urgent care recovery programme board, with oversight by the Anita board. And I will, of course, keep the board briefed as we go through winter on that. In respect of the recovery and restoration, We've developed the H2, the second half of the year activity plans, including the focus on the clock stop, so that the guidance has changed from what we focus on to access the ERF funding. So we're ensuring that all our processes are timely and accurately captured in order that we get the clock stops right. And we're also focusing on the restorative activity, really making sure that our waiting lists are hopefully coming down in a number of areas. The H2 guidance specifies that there's no deterioration in the number of over 52-week waiters from September through to the end of March, and our plans will support that. And they also specify that we have 0 over 104-week waiters, excluding those patients, if you recall, that we had on a pending list on our per and ARC list that we had recently to move back onto the active waiting list. So we actually will have 383 patients sitting there on the 104s who are those P5 category. And that was the submission earlier this week for our H2. I just wanted to flag that we've actually looked at that again, and we're going to reduce that down. We think we've got some more validation to do, so we're going to reduce that down to 80. But it's other than those ones who are fearful to come in, because those are the P5s, that figure will be 0. So focus in H2 will be on delivery of that recovery and that restoration, as well as the continued improvement that we want to see in our cancer and other elective standards as well, because we have been seeing good improvement there. And the activity through H2 is based on what we did in Q2. So we're not being overly ambitious. So, you know, high levels of confidence that we'll be able to deliver against this plan. That's probably it from me, Chris. Thank you.
Thank you. I'll just take some questions from the floor, Chris, in relation to the papers that have already been presented. Just before I bring you in, Jill, Kate, could you just pass our thanks as well to everyone that's been involved in the 104-week targets, because except for those, as you say, in category 5 and pending, to bring it down to 0 is a remarkable achievement. So please thank everyone involved in that. Jill?
I just wanted to ask about those people who are delayed discharge. I know we're not using that anymore, but you know what I mean by that, and so does everybody else. We at Quality Committee, and it's alerted in our Quality Committee paper, we heard that the community care group are experiencing pressures in accessing domiciliary care and residential care enabled to help people out. Every week we see the report that we're 98, 85% occupied, and we know the impact of this on increased falls. It's one of the big issues of quality for our trust. And yet we've got fantastic partnership working. We're always hearing about all these wonderful partnership initiatives. What do we have to do to make a difference to get people out of hospital who shouldn't be there, so that we can make sure we give a quality experience to those people we do treat?
I think there are a number of...
You may not be able to answer this, Kate, but I think we need the board to focus on it.
Yeah, no, that's fine. I think the solution is workforce and a return of workforce into the care sector. What we've tried to do to help our partners, because they are struggling to recruit, is to recruit into our hospital home care service, which can then help, if you like, bridge that gap a little bit. So that's what we've been focusing on. However, we have also been experiencing recruitment difficulties. We're looking at the same sort of grades of staff. So that's the difficulty. So that's when I say that we're trying to explore other ways. It's actually, what other ways are there to be able to support people either at home or in another setting, which might not be at their home, but not in an acute setting, because that is then obviously adding to our occupancy. So yeah, there is.
It strikes me it's a bit of a national issue. So what are we doing to raise this nationally? We've got it as a high level of risk. What are we doing to raise it nationally to say, actually, there needs to be more funding in social care, or there needs to be other solutions for social care if we want hospitals to catch up?
Kate, it's all right. I'll bring the chief exec on that one, if that's okay.
Yeah, thank you. So this is a platform at the ICS that's being created with other partners across local authority, the ICS regional teams, and is featuring with conversations up to the national teams. You'll have seen in the recent headlines about proposals for changes in social care funding, around changes in kind of the social care environment to encourage recruitment. I think in the meantime, because obviously those things can take time if it's policy driven or politically driven for solutions to feature, we need to make sure that as a place-based partnership in the ICS, we're deploying what we can to offset the risk. But absolutely with you, Jill, that these things need some solutions that sit out with of this trust board. So we need to be clear on what we can do, we should do, and we do it well. Where we have risk, we manage that risk as a partnership as best we can. But we take full opportunity to raise this at the regional level and the ICS level for contributing our feedback into that national conversation. Absolutely agree with you, yes.
Okay, thank you. Yeah, we'll keep doing that. Chris, if I bring you back, we've still got people in finance, so please don't. Oh, sorry, my apologies, Hugh.
I've just got one more technical question. I think the idea of clock stops and clock starts is just recently been introduced. Is that right? And it might be helpful just to understand exactly what they mean. I did a bit of digging to try and work it out, and it's I think I understand it, but I don't actually understand what the 89% threshold, which is quite a key threshold in terms of us receiving extra resources is, and it's the 89% threshold based on where we were in 2019-20. I think I'd like to understand that, if possible, and I'm sure other people, any public on the call would appreciate to understand that as well.
Okay.
Right, clock stops. So actually it's a reintroduction and focus on clock stops. So when RTT was first introduced, it was absolutely about stopping the clock, referral to treatment. So the time from consultation in the GP practice and referral through 18 weeks to actually a treatment starting. And originally you were measured on that length of time. It's changed over the last few years and it's just come back in. The issue about clock stops is that there is a small Bible of rules around when you can stop a clock and when you don't stop a clock, and it requires quite a focus and attention. So the 89%, I'll probably look to Chris at this point. I think it's linked to the financial framework around the ERF, access to the ERF funding. Is that right, Chris?
It is, Kate, but it is we accept it is complex, and
So
yeah.
I just want to understand what the 89% of what. So is it is it 89? Well, I don't know, so I won't try and.
It's of what we did in 2019-20. So all of our restoration percentages are compared not to 2021, because of course we're in the middle of pandemic and everything was different, but to the previous year, so 19-20. So when we talk about we need to do 110% restoration rate, it's compared to what we did in 19-20.
So just from so just 112%, is that good or is that bad?
That's good.
Ah, right. So we're doing right. That's what I was struggling to understand. Whether so compared to 19-20, we're doing actually much better.
Yes, and our plan says for 82 we'll do 103% of the clock stop comparison. So the 112 is overachieving in October, which is great.
Oh, good. All right,
Sarah.
Thanks, Mike. So it's about a separate thing. It's about the stroke report, page 119, and it's a little bit about what does good look like. So obviously we've got the quarterly reporting, and I know we receive separate reports on this, but I'd really value understanding what the goal is, and also if there's a timeline for that. I know that's a separate report and we've looked at that, but for the purposes of performance reporting, if we had a sense of where we're aiming for, we'd know how we're performing against that, and that would provide some assurance, I think.
Who would like to respond to that? Kate?
I'm happy to respond. I'm sorry, I can't find page 119 at the moment. I'm on a different version. So what we're aiming for with stroke is, first of all, to meet the improvement criteria that we need to within the Section 31. But beyond that, it's about improving our SNAP performance. And I would say we're aiming for an A. Others might think we can't aim for an A, but I think we should be, our ambition should absolutely be for an A on each site.
Thank you, that's very clear.
Thank you, Kate. Chris, I am conscious we've got people in finance. Could you take us to that, please?
Yes, I think Dave will come in here on people and I'll wrap up with finance at the end, Chairman.
Thank you. David?
Thanks, Chris. So the key thing I wanted to update the board on was around mandatory vaccination, which you will be aware now becomes a condition of employment for frontline staff from the 1st of April 2022. Currently, this is only going to require the 2 COVID vaccinations, doesn't apply to booster, and national guidance around this was expected last week, but hasn't yet been received. Notwithstanding that, we already had a task and finish group in place looking at this issue, and that has already started to look at how we're going to implement and milestones for delivery, and have actually produced their provisional plans subject to confirmation on receipt of the national guidance. In terms of scale for the board, we currently have 537 individuals that we have no record of vaccination for. We've split this now by job role and department so we can isolate those that meet the frontline criteria. Our approach is to work through this through compassionate conversations, education from line manager, and support has been offered from our staff side colleagues in those compassionate conversations too. We're also arranging seminars from Professor Craig Williams and Dr. Phil Atkinson, and we'll be utilising other educational resources made available nationally. The major milestones have been agreed. The pivotal date is the 1st of February, which is the date by which the first vaccine needs to be completed by in order to have the second vaccine by the end of March. We'll continue to update on progress through the People Committee and via the IPR report.
Thank you, David. So you've alerted us to the issue around staffing getting their vaccinations, number 1 and number 2. You've assured us that there's a working group looking at this and it's going through the People Committee. The deadline date is the 1st of February, and you will advise the board accordingly of any assurance and risk to patient care through the appropriate processes. It's very clear. Thank you. Okay, there don't seem to be any questions there. I think we've had a discussion amongst the non-exec directors about this just this week, so we are aware of the issue there. Can I just check who's just put their hands up there? Karen Thompson. Karen?
Yeah, thanks, David. Does the figure of 537 include bank staff, or is that just substantive staff? And do we know, if it is just substantive staff, do we know how many bank staff haven't had the vaccine?
And the 537 is substantive employees. We've still got to work through the banking. Really good question, Karen. I haven't got the data, but we're working that through as well.
Yeah, because I think that might have further implications. Yeah, thank you.
Very good point. Thank you, Karen. Chris, back to you.
Thanks, Chair. So the finance section of the performance report is rather unusually more of an update on half 2 planning than a detailed presentation of plan versus actual. So the planning guidance and timetable for the second half of the financial year was only issued at the end of September, 30th September, and actually initial planning submissions were due last Wednesday, with the trust's the component of that due today. So it's only at this point that the trust's allocation has been confirmed and the detail of budget setting has now been finalised ahead of our submissions going in. So whilst there will be an update in respect of the discussions at Finance and Performance Committee later in the feedback from the committee, and by the way, I'd just like to thank again the Finance Committee for its flexibility in supporting us to get through a very difficult and time limited process. Within this context, only a headline assessment of the month 7 financial positions included in the performance report as a £500,000 overspend against an initial trajectory to the break-even target for the second half of the financial year. To make this a meaningful report, of course, we need to load up the eventual components of the plan, and that, of course, hadn't been done in time for this report. And actually, the basis of financial reporting will bring together month 7 and month 8 because of the half-year planning timetables. So whilst the overspend against our initial trajectory was partly the result of the significant operational pressures and related to some of the challenges that have been reported in the integrated performance report, the most significant variable at this stage is the final phasing of efficiency plans for the second half of the year, and in particular in relation to stretch targets and the integrated care system financial recovery plans. So the report in December will provide a much clearer analysis of the overall profile of this plan, and therefore a better informed update on the relative position of the organisation against this plan. The report makes reference to specific immediate attention required to address the identified deficit in the remaining part of the financial year. I can advise the board that Trust has in place significantly enhanced financial improvement, development, oversight and management arrangements for the second half of the year, and that we're working hard to ensure that our internal risk management arrangements associated with the plan are similarly targeted around the key plan risk areas, as well as being fully aligned to similar processes across the ICS, which members of the trust are playing a proactive role in as well. So the trust work to establish its longer term financial improvement trajectory is also underway, and they're specifically connected to the recovery support programme and its component work streams, with specific mention in this context the interconnection between sustainable financial improvement and the quality and safety work streams. So we'll develop our reporting around that context, but I wanted to explain to the board the limitations of the financial information available for this month's meeting.
I think that's very clear, Chris, and hopefully we will have the guidance for the December board. So my question to you really around finances, any issues related outside of the risks that you've pointed out to us, and which you, to be fair, pointed out every month, anything related to the board assurance framework or the risk register that you need to bring to our attention at this stage?
Specifically on finances, Chair, I've asked for a review of that in the context of the plan that has been finally set this week. Sorry. So we will formally update that through the normal process from this point.
Could I just request that through Steve's finance committee that they look at that around the BAP and the risk register? Thank you.
Yeah.
Okay, I can't see any questions to you, Chris. Thank you for taking us through the integrated performance dashboard. I'm now going to move us on, colleagues, to the next item. Thank you to all our exec colleagues who presented the information there. We know the reports that you've given, subject to the feedback and comments that we gave. So item 1672, these are the minutes and the 3 alert, assure and advice reports from the Assurance Committee. If we start with 1672A, Finance Committee minutes and the 3A reports for the 25th of October, and an update from the meetings on the 15th and the 22nd of November, plus provide an update of the half-2 submission. Over to you, Stephen.
Thanks, Chair. I think all I'll do is just pick up where Chris left off, really, on the half-2 plan. We have a plan, which is the good news. Of course, we are a third of the way through the period that plan relates to, which is less good news. I think the interesting thing is that one of the main reasons, as I can see it, for the delay has been the challenge of getting all the providers to commit to their part in getting the ICS to come to balance. So that seems to be what's taken the time. And the interesting thing will be that they have all made, including ourselves, assumptions and signed on to assumptions to get us to a figure. And they've committed to, firstly, transparency of reporting between each other,
And secondly, a commitment to go back and renegotiate assumptions if they don't turn out to be accurate. So that's new, and I think what will be interesting is to see how those commitments are met against the backlog of huge pressure that we've just heard about from the operational side and a lot of mutual aid going on. From my perspective, it certainly seems like there's more collaboration, both from an operational and a financial perspective. But it'll be a real challenge from here to the end of the year to actually see that continue, I think. The one mitigation I think we've got in our plan, hopefully, is that a lot of it's been based on Q2 experience, and the committee was really noting that, I think, in our meetings. Hopefully, some of the measures that have been taken both on the staff and managing volumes will have some benefit, which will give us some leeway, but that's a hope, I think. I think that my final comment will be, obviously, earlier in the board, we talked a lot under the urology report and TNO about the cost in terms of risk to patients of dysfunction. I think I would just highlight that there's also a cost in terms of financial resources from those situations. And I think as we deal with those and as we reduce the incidence of those, we will see benefits on the resources that we consume, and that will help us on the route to sustainability. I think that's all I would say. Chris has put in place, new arrangements, but what we really need to see now is evidence of that efficiency gain coming through in the monthly numbers. Thank you, Chair.
Thanks, Steve. Just looking round, I think we accept your report. Yes. Okay, the next one I've got is the People Committee. Adrian isn't here, but Bruce, would you be able to update us on any issues that can come from the People Committee to the board?
Chair, I'm not on that committee.
Apologies. David, could I ask you as the executive?
Yeah, sorry, I think that the key thing to note from the last People Committee, we received an update on the latest version of the People Plan, which include our OD plan on a page, which again links across to the recovery programme, and we will iterate that depending on the outcomes of the cultural engagement tool and the actions that we need to take as a priority.
Thank you. Concise as always. Again, I think we accept that report. We have the written reports in the agenda papers anyway. I'll go to the Quality Committee. Jill.
Thank you, Chair. First of all, I want to say thank you for getting these 3A reports on the agenda today. Whoever was responsible for that, I thought it was really good. And this is demonstrating what we've done and changed since we had indications from GGI that our governance wasn't right in response to some early indications from the niche review. So this is a way that we can actually be clear that we're reporting from quality and other areas straight back to board. And interestingly, the two alerts I want to raise today are things that were raised in the niche report as well. The first is about some issues about electronic patient records and actually recording. And the reports we've seen today also raise some of the weaknesses on recording. And the Quality Committee are actually waiting to see a plan to address some of those weaknesses. And I don't need to say any more about it, but I just want it recorded that we will keep an eye on that. And the second is about the action plans following incidents that happen. And one of the action plans, and we were concerned about, following on from some never events, was about human factors specialist training, which had been done face to face and had been shown to make a difference to the learning. And yet there had been some issues about whether that was ongoing, and we wanted to raise that here today at board as an alert to make sure it's looked into, and where that action plan needs to be delivered, be assured that it will be delivered. And that's it.
Thank you. Thanks, Jill. Again, I'm looking at colleagues and we note and accept your report. Thank you. And I'll move on then to the Director of People and OD, David, item 168, the positive difference strategy.
Yeah, thanks, Chair. So just over 5 years ago now, we our first ever EDI strategy towards inclusion was presented to the board, and we adopted that after a period of extensive internal and stakeholder engagement. And that strategy has very much laid the bedrock, really, of leadership infrastructure and networks that have supported delivery, and have seen us over those last 5 years gain quite significant external recognition for what we've done around establishing infrastructure. And that culminated in the Trust being awarded the most inclusive employer in the Inclusive Companies Awards in 2020. When we go back to 2016, our aim then was for effortless inclusion, and on reflection, as an inclusion and diversity steering group, we think that whilst that was well intentioned, it was naive and was an oversimplification, because for EDI to be fully embedded, it needs significant effort, it needs significant profile, and it needs significant action. And in many respects, effortless downplays the profile it requires. Our new strategy, Positive Difference, moves away from the establishment of processes, networks and transactions that was at the heart of that previous strategy, and is now focused on aspirational but achievable outcomes that we want to deliver on over the course of the next 5 years. For it to succeed, it needs to make a material shift in EDI so the agenda is owned by everyone, not the few, fully embedded across everything that we do. And it comes to board today for final approval, and following this, we will start taking the steps to create that positive difference every single day.
Thank you. Colleagues, we are asked to approve the new positive difference inclusion strategy for 21 to 26. We have the report in front of us. I'm looking round. Aaron?
So I absolutely agree, with the intention versus what signals that gives and how much effort and time and focus as a board actually we apply to this agenda. But it's just a bit of assurance that, so some of the core infrastructure of our previous strategy, the intention is not to step away from that. That will be retained, but we are then using that as a platform to focus in the way that you've just described, as opposed to just a transactional infrastructure focus. But that good infrastructure that we have will be retained.
Yeah. A lot of the intended outcomes of that first 5 years was to put the structure in place rather than to deliver against, make material difference. And that's the distinction I was trying to make, Aaron. I think we already consolidated. We want to build on the structure moving forward, but shift it away from those people are there to support, they're not there to deliver everything, and that's where it's about everybody taking ownership for the agenda moving forwards.
Thanks, Dave. Just a second point if I can, Chair. I think one of the reflections we've had through the good governance work, not that it necessarily sat as a recommendation, is that the board too often agreed strategies, and then the only time that it got assurance on that strategy in particular was when it was due a refresh. And we drew attention to using our quarterly reviews as the way we give a strategic or a more strategic update. But that's not the same as saying at 6 month or 9 month intervals on the positive difference strategy. Where's it up to? How's it achieving? What assurance do we get? What trajectories are we hitting? And it also isn't just in the IPR. So I'm going to use this one as a bit of a guinea pig. But when we look at the forward board agenda, Paul, and with the chair, we'll agree with Dave on this strategy and as a signal for other colleagues who are developing strategic documents. How and when do we bring back to board a review of how the strategy is being deployed and its relative success that isn't just in annual reports or quarterly reviews?
Yeah, I would support that proposal from the Chief Exec, particularly if we use the matrix measurements and some evidence-based data that we discussed in earlier meetings today about the various reports we've had, so that we can have not just an annual update, but a regular update on how is this being embedded, what's the pace, almost like, you know, what is the percentage rate towards that overall goal and objective for the last year of the 5-year plan. So I would utterly support that. Colleagues, I think it's unanimous then. Thank you, it's a really good proposal. Okay, then we approve the new positive difference inclusion strategy 21 to 26. It will come back regularly to the board, not just as an annual event. We'll work a timetable and you'll provide us with data and some evidence streams and also related to the BAF and the risk strategy where relevant. Thank you. Okay, we move on to item 169, the Bay Health and Care Partners update. Again, you've got the report, we've received it. I asked the Chief Exec to bring the main points to our attention, please.
It's there to note this month, Chair. I think the main 2 items for highlight are a significant workshop last week for the place-based partnership to consider how it's going to operate and how it will relate to the new system reform agenda. Some really good stuff came out of that. We're going to bring it into the leadership team and then back into a end of January workshop to finalise, and it'll feature at the board here with any proposals for how the partnership will establish. And then the second is quite a significant piece of work with the HEC around population health focus and a report from the partnership to go back into the regional work with some very clear and explicit expectations of what we want that structure to help us with. And again, as that gets agreed, it'll form part of our own population health delivery plan ambitions in our strategy, Chair. So just 2. There's a lot in the report for people to read, but they're the 2 items I would highlight.
Okay, thank you. We note the report. We move on to item 170, asking the Chief Operating Officer to come in. New hospitals programme update. Again, we've got the report, we've got it in front of us. I would ask that the Chief Operating Officer brings to our attention any of the main points from the report for the board to consider, please.
Thank you, Chair. We've actually got Jerry with us today.
Oh.
So joined.
Welcome, Jerry.
Hi. So you've got the Q2 report in front of you, which describes what's been going on in those 3 months. A lot of work going on around the key products, the framework model of care, developing that long list, and all the engagement work that's going on. And also lots of work going on around the detailed estates work with a number of the options. There's a key opportunity coming up at the beginning of December with a meeting with key people from the national team and the NHS Commissioning Board, really to share what we've been doing, share some of those options that we've been working up in more detail, how they compare to the case for change. But Jerry might want to add a little bit more to that as he's in the thick of that.
Okay, thank you, Jerry.
Yeah, thank you, Kate. And just to reinforce that message around the spread and scale of the engagement work going off across Lancashire and South Cumbria, we've had some very active and positive road shows that have been well supported. It is not at all surprising to hear that the public consistently raise concerns around travel times and accessibility, but is also pleasing to report the overwhelming support from the public for the new hospitals programme. As Kate says, we are meeting with NHS England in early December to talk about how the new hospital programme is very much an enabler for our wider system reform, whether we look at that through the lens of our clinical strategy, operational approach or financial performance. So significant work going on. I'm very, very grateful for the support from the Trust staff who have been pivotal in us bringing together our latest proposals and a very active programme over the next month or so. Thank you, Chair.
Thank you, Jerry. I think we are asked to note the progress undertaken in Q2. Yeah, we know this is a live issue. We'll keep coming back to the board. And in your papers, 170 Roman 1, we have got the revised strategic oversight group terms of reference. It clearly states in the summary the strategic oversight group have reviewed and approved. We've also got a note there, the chair and the chief officers of the ICS have also approved these, and it's coming to our board to approve the revised terms of reference. Colleagues happy to approve? Richard?
Chair, just on the terms of reference on page 203 of 223, Shahid is still there. Is he maintaining that responsibility?
Thank you for that.
No, we'll need to make that amendment, Chair, replace Shahid with Jane.
Yeah. Jerry, just for your information, we will replace Shahid with Jane as our medical director. Thank you for that, Richard. Any other issues on the terms of reference? No. Thank you. Then that's approved by our board. Jerry, thank you very much for that report. Kate, thank you for the introduction. We'll move on to item 171, the Good Governance Institute. This is a presentation of the review conducted by the GGI. Over to our Chief Nurse.
Thank you very much. Can you bring the slide deck up, please, Nicola? So I think, again, this is another really important report here to the board. This is the outcome of over a year's work that we've been doing with the GGI, so I think it's really important. I would like to thank Andrew Cobbett-Nolan and David Holden and the whole GGI team who have been working with us. One in pulling their report together and the slide deck, but working with me this week while we made sure that we were all comfortable with what I was going to be presenting to the board, and thank them for that. And they understood that we had a big board today, and that's why I was doing it. But there's been excellent communication and support in bringing this. So next slide, please. So that's just there about the importance of the work streams and the principal outcomes of improvement. So next slide, please. So here we've got a range of things that the GGI have done and worked with the Trust over the period that they've been with us. And I just wanted to say this really captures the breadth and depth of the work that we've been doing, so that they've done the well-led governance reviews, they've done risk management support, they've done a review into risk management in estates and facilities. They've worked with our Council of Governors. They've done some big work around training and communications on what risk is and how we do incident reporting. We've had board development, the development of a board risk appetite statement, and then they've actually helped us to establish the new assurance structure. So looking at those three waves that we've gone through in embedding this. Again, they've worked with our company secretary looking at the board assurance framework, and they did some specific work that we asked them to do around the perfect month. So how could we be assured that what we were doing was actually working in practice, and they were able to show that and support that. So next slide, please. And the next one, please. And the next one. Thank you. So again, they want me to talk a little bit about the principal impacts of the programme and what has been achieved. So next slide, please, Nicola. Thank you. So I think there's some real key metrics on here that we need to take account of, because what we heard about when GGI first came was about the amount of meetings we had, the layering upon layering of systems and processes to give us the outcome that we thought we wanted. And what they helped us to do was to strip everything back and to start again from a clean piece of paper, but also to establish those firm foundations. So they've described here, and I'll pick a few out if I may, so a 50% reduction in the number of meetings held in the Trust Governance Assurance structure. The staff have actually rated improvements on how they think meetings are operating, how clinical governance is improved in the organisation, and also that the risk management processes are moving along. So they're recognising now what good risk management does. I think what's really important to say, and it comes out a bit later, is that this is not a finished product. We've got to keep sustaining and building upon this. So whilst this is really good, I would hope if we're now in contact with the GGI going forwards, that we will see these levels of improvement increase. So they reckon that they've estimated around 1,040 hours of executive director time has been released from attending meetings. So I think that's something we really need to look at, because as we go forward, we've got quite a lot in niche, trauma and orthopaedics and other things where we really need to focus that leadership attention. So we need to bring that through. And they've recommended that we should adopt a formal policy of engagement between the Trust Board and our Council of Governors. And I know the Company Secretary has been asked to look and lead on that. So thank you for that, Paul. So next slide, please. So in here and in this slide, it talks about what they've heard from the staff during their evaluation, and two areas that I really want to pull out, and I think we've seen them in demonstration today in the board, and that is the introduction of the 3A's report about assuring, advising and alerting, and we've seen those flow through papers today, and it's supported the meetings to be more focused, and I think we are definitely getting there in that and escalating those key risks and issues. Also that they think there's better awareness of issues escalated within the organisation, and I think for me, having been at Risk Management Committee this week, there was an acknowledgement there that actually we were discussing the right things, and they were flowing into the organisation in a better way and up and down the organisation. So, and rightly so, that there was some pushback on some things and some constructive challenge. So again, I think that's a really good thing that I think GGI has helped us to get into a place of. What they do say, though, and it's right, that we haven't really begun to see all the benefits of this work yet, and we'll probably see those in the next 6 to 12 months. That's depending on us maintaining and sustaining and embedding the work that they've started off for us. And I know from Richard and my point of view, this is absolutely key to what we believe needs to be happening as well. Next slide, please. So, they just provide us with a high-level overview of actions. So if we go on to the next slide, again, these are the next steps that they are recommending to us. So they want us to take forward their recommendations for sustainability as outlined in the final programme report, and Richard and I will be having a conversation about that later. They also want to come and meet Richard with Bridget, our new chief nurse, in January, and probably Jane as well as our medical director, just so that they can just explain what they've done and where they've been, and I think that's a really good thing to do. They've accepted, well, they've asked us if they can keep in regular contact with them, and I've accepted that on behalf of the trust, because I think that's the right thing to do. You know, when you've worked with a company for so long and they've done some real fundamental work, then I think they also deserve to know how we're going as well as an organisation. So I think I'm going to stop there, and happy to take any questions, but I think it has been a good piece of work. I know it's been difficult at times when we've had to turn off parts of the system that people always knew and bring new ones up, and we've had to train people. And I think we heard a little bit about human factors, which was work that we brought in through GGI as well. So the stuff there that we need to do, but I think the ownership and the leadership of this needs to be absolutely spot on for being embedded and sustained. So thank you.
Thank you, Jackie. Many of us here have worked with the GGI. Yeah, some new members haven't, but you may have worked with them in the past, and we worked with them on this work that you've outlined. And then we have the paper in front of us. So thank you for that, Jackie. And the slides were a really good summary of the work that GGI have done, and actually how different the trust is compared to what it was when they came here last year, really. So I can't see any hands up. Steve, sorry, my apologies. Steve Ward.
Thanks, Chair, and thanks, Jackie, for that summary of where we are. I think it hit the right note for me. It's good that we're getting some benefit, because there's an awful lot of effort from colleagues across the organisation engaging with GGI over a long period. Thing that struck me, there's a comment on page 76 in the report that said care groups generally felt they were still attending the same number of meetings, and actually that's feedback I've had from one care group that I've engaged with. So I think we just, as you say, we just need to keep at it, because it's not been just about changing process, has it? It's about changing the quality of the inputs to the assurance process, and for me that's where we need to focus now. We've done a lot of training, we've done the obvious, but we've got to keep at it to really get the benefits of GGI's long engagement with us. Thank you.
If I may, I think that's a good reflection, because you do hear that. I know one of the big committees that we took down was the Patient Safety Summit, and we've been thanked for that. So that is one that we can see that was actually taking about 5 or 6 hours of care groups' time in pulling that together. But I think when you look at that, we've got to be careful ourselves that we don't start bringing old structures back in because it's comfortable. It's about making sure we do the right thing. So I think there's a fine balancing act here, but we need to make sure that it's productive time for any of our staff members, especially as we move into winter now, which is, we know already it's going to be very hard. So
thank you, Steve. Aaron?
Just a quick reflection for the board, really. This was quite a brave thing to do, actually, in the middle of the pandemic, to take a decision to do some transformation work within the very wiring diagrams of assurance, governance and risk. And I think, it's been a bit of a dichotomy today, hasn't it? Because we've got some really good reports coming of proposals for change or change that's been delivered that we'll see some outputs from, that will address some of the issues that we've spent time talking about today, either in urology or trauma and orthopaedics. And I think at the time we did face a little bit of a conversation, didn't we, about whether it was the right time, the right resource, the right way. What we need to do now is take that platform and make sure that we have the discipline to make sure that that thing stays as it should. It's MOT'd regularly, so we know its effectiveness and its levels of quality in terms of how it's being used are effective and improving. Because my reflection of governance is it's a fundamental, people have heard me say this before, it's like the circulatory system of an organisation. So when it works really well, things just flow through, risks get managed, decisions get taken. When it's not so good, you have an infarct, stuff get blocked, you get a pop-up, you can't manage effectively. But it also needs regular health checks. So we can't afford to have this on a shelf, say we did the report, we've got the recommendations, and in 3 or 4 years' time, we've got the same 747 meetings that we had and things haven't happened. So there's a discipline to keeping this work where it needs to be. Really pleased with Jackie's overview. I know Richard's absolutely 5 by 5 kind of looking at this infrastructure and we'll want to nurture it and develop it and make sure that it's kept absolutely where it needs to be. But it'll mean some board discipline, both here in this meeting and in the respective assurance committees, with the temptation to set up a subcommittee or set up a group. There needs to be some discipline of gatekeeping roles through Richard's good offices and the company secretary's offices. So it's good. I think it's given us a platform. I think we're in a better shape now than we were when the work started. But this is going to take some nurturing and some development and some continual focus. And I think we've got the right colleagues with us that allow us that to happen. It's a good piece of work.
Thank you.
Just to conclude that there's the recommendation.
I'm taking 3 recommendations to the board. We're asked to note the content of the report first. Thank you, Jackie. We accept that. The second recommendation is to support the recommendations and the actions of the GGI report itself, particularly that spur to keep on going and build on what we've got. I assume we all accept that. And thirdly, that the Director of Governance will provide an update on the action plan to the Quality Assurance Committee, who we're charging to take on the points that Aaron raised, that we maintain discipline, we don't start growing subcommittees like Topsy. If anything, we try and reduce the committees in the trust and get down to the basics of good patient quality, safety and care. We accept that? Thank you. And we'll move on. If we could get something back to the Good Governance Institute, formally thanking them for their work and the work that they've done, and perhaps keep us up to date on how the liaison and comms with them are going. Policy input.
I'll take that responsibility. I'll have a catch up with GGI next week.
Great, thank you, Richard. Policy and publication report, item 172. It's just a reminder. Anything there to bring our attention?
Just for note, Chair.
Okay. And then just before I do the closing admin, I'd like to thank Deborah Turner. She's been with us all day. It's been a long day. Deborah, if you're still with us, thank you very much. And Damien as well. I know he didn't come this afternoon, but thank you for his contribution, the work he's done, particularly around the trauma and orthopaedics. And I'd always like to minute and thank in the public board to Caroline Griffiths, to Damien Riley again, and to yourself, Jackie, for the work that you're doing with all the improvement work. Our formal thanks to you. Jerry, if you're still there, you've probably gone, but thank you for the new hospital programme update. And I'll move on then to closing admin. You have in front of you the attendance monitoring register. You have the schedule of business. Paul, I always check with you, any urgent business? None have been brought to my attention, but anything to you as company secretary?
No, not for this meeting, Mike.
Okay, and then my last point, do you feel as a board that we've dealt with the items today, that none of you will leave this meeting feeling that issues haven't been covered or that you didn't get the opportunity to raise anything? No, thank you. And that you feel that all the agenda items were covered in a good and an effective way? Yeah. On that basis, then I will close the meeting. Date and time of the next meeting is in the papers. I close the meeting at 17:19. Thank you, colleagues.
Thanks, folks.
Thank you, Chair.
Thank you.